Today in afternoon we are going to talk about toxicities associated with immunotherapies more for hematological malignancies. Some of the drugs I also don't have any experience, more of a literature I am reviewing it. Some of the drugs, the people who are working in the solid tumors may have a more experience than us, but I'll go through the literature and then we can discuss about. We as a hematologist know immunotherapy from our transplants. The allogenic transplant is going on since 1968, since Dr. Thomas had done a first transplant. This is one of the oldest form of immunotherapy. The immunotherapy works in hematological cancers. The allogenic transplant is a proof of sensitivity of hematological malignancies to immunotherapy. We know the graft versus leukemia effects. Where the chemotherapy doesn't work, the lymphocytes, the donor's lymphocytes works against the chemorefractory disease. Use of donor lymphocyte infusions to treat the relapse after the transplant also indicates the immunotherapy, there is effectiveness of immunotherapy. And the concept of reduced intensity conditioning transplant for older and unfit patients also relies on the lymphocyte based killing of cancer cells. So we have been working on this immunotherapy as a form of transplant, and this proof is there. We have cured many people with the allogenic transplants, but still we struggle. This is one of the blunt immunotherapy. We lose many of the patients with the non-relapse mortality, and still many of the people relapse. So it is not a very effective immunotherapy. There are some people, the major cause of death is a refractory disease. What are the unique features of immunotherapy in hematological malignancies? There are some advantages and there are some challenges. Immune responsiveness, as we know from DLI and transplant, the malignant cell and the immune cell both are in the same milieu. So there is a close and constant opposition of the malignant cells to the sites of immune profiling. The origin of the malignant cell is also related to the immune cells. So the origin is same. Whether this is an advantage or disadvantage, we need to work it out. And we have a feasibility of isolating the cancer cells. It is in the blood, and you can collect the cancer cells as many times you want. So there is no challenges with the collection of sample. What are the challenges? Malignant cells can be stimulated by the inflammation. If there is any inflammatory process going on in the blood by the immune system, that can also stimulate the malignant cells. So the process which can stimulate immune cells can also sometimes stimulate the malignant cells. Basically, the malignant cells are evading the immune system. That's how they become malignant, in spite of being into the same milieu. So probably there's exceptional ability of the malignant cells to suppress and evade the immune system. So these are the challenges when we use immunological weapons against the hematological malignancies. What are the strategies so far we have? Direct targeting the tumor cells, tumor antigens. We have a monoclonal antibodies. The first immunotherapy we had as a rituximab, then antibody drug conjugate, bispecific T cell engagers, the BiTE cells, and CAR T cells. So they all have action directly targeting the tumor antigens. Augmentation of immune effectors. So the CAR T cell do the job of augmenting the immune system, and the NK cell therapies have the principle of augmenting the immune system. Activation of tumor antigen specific immunity is by the vaccine has not been very successful so far in hematological malignancies. Overcoming the tumor derived immune inhibition, now we have a checkpoint inhibitors, they overcome the tumor derived immune inhibition. So these are the various strategies which are available so far. Is in the cartoon form. We have a checkpoint blockage with the checkpoint inhibitors. Agonist antibodies, we know the naked monoclonal antibodies, or there are various mechanisms for the antibodies to work directly on the antigens. T cell engagers, we have belantamab or other antibodies. naked and ADC antibodies, as I said, rituximab and Herceptin, engineered T cells, which are CAR T cells, and TCR transduced T cells. We'll go through with them one by one. I will come to the direct targeting of tumor antibodies. As I discussed, the monoclonal antibodies, antibody drug conjugates, and bispecific T cell engagers. Monoclonal antibodies, they have a various mechanisms: antibody dependent cellular cytotoxicity, antibody dependent phagocytosis, complement mediated cytotoxicity, and direct toxicity. The first anti-CD20 was a rituximab. That was a prototype of CD20 monoclonal antibody, and it has become a backbone of almost all B-cell malignancies. The newer anti-CD20 antibodies, ofatumumab, single agent efficacy in the relapsed and refractory CLL, or it can be combined with the chlorambucil in newly diagnosed CLL. Obinutuzumab, this is combined with the chlorambucil in newly diagnosed CLL. We have many monoclonal antibodies in myeloma. One of the most commonly used is daratumumab, anti-CD38. It has shown a very significant activity when it has been used in heavily pretreated population, showed an overall response rate of around 42%, but when they have been combined with the lenalidomide or bortezomib, the overall response rate has increased to 75%. Very well tolerated. Main toxicities are infusion related, and that got a breakthrough designation from FDA in 2013. Elotuzumab is not available in our country. It is anti-SLAM F7. This is a single agent use, didn't show much of a response, but when it is combined with the lenalidomide and dexamethasone, have shown a response rate of around 79%, and this also got a breakthrough designation in 2014. There are many more monoclonal antibodies against the anti-CD38, CD138, CD56, CD40, B-cell activator factor BRAF. They are in the pipeline and under development. These antibodies have many immunomodulatory and immunotoxicities which may be harmful or advantageous for the cancer cell killing. We'll move to antibody drug conjugate. One of the most common, the most old one drug conjugate was the gamotuzumab, which was used in AML. Was taken back, has come back again. Another one which is most commonly used is the brentuximab in Hodgkin's lymphoma. The immunoconjugate, the antibody with the effector molecule, the cytotoxic agent, they go directly and kill the malignant cells. Brentuximab has been approved by FDA for relapsed and refractory Hodgkin's lymphoma, and recently there have been a large trial for upfront use along with the AVD. There are many more drug conjugates are in the development, targeting 138, targeting CD19, CD33 and others. So we will be seeing many more drug conjugates in near future. Another exciting direct acting antibodies are bispecific T cell engagers, which we call it commonly as a BiTE cells. One of the most prototype of this is a benatumab, which is used in ALL and B cell lymphoid malignancies, which has a this is a dual specificity for CD3 and tumor surface antigen. So belantamab has a tumor surface antigen is a CD19 that leads to the passive recruitment of cytotoxic T cells to the cancer cells, and that catalyzes the catalytic formation of immunological synapses. These are polyclonal responses. They are independent of MSC expression, so they overcome the common mechanisms of tumor immune escape. Belantamab is combining anti-CD19 and anti-CD3 formed by the linker. It's very effective. It is phase 2 study involved 189 patients in relapsed and refractory ALL, had shown a CR and CRRI of 43%, and half of them could proceed to the allogenic transplant. We know we don't have a very effective salvage regimen for relapsed and refractory ALL. It has been approved for use in relapsed refractory pH negative ALL since December 2014. The only disadvantage is it requires a continuous infusion for a longer period. There are various bite antibodies in development. So the one is the belantamab has been tried not only in the leukemia, it has been tried into lymphomas, mainly diffuse large B cell lymphomas. CD3 and CD33 white cells for use in acute myeloid leukemia. Whether you can have NK cell engagers, instead of bite we have a bike engaging NK cells close to the tumor cells. They are in development. There are many, none of these antibodies are without major side effects. One of the antibodies, the belantamab, the most common side effects are febrile neutropenia, 1/4 of the people, nausea, pyrexia and peripheral edema and headache. So these are most manageable, the common side effects. The most dreaded side effects will be cytokine release syndrome. I will be coming to the cytokine release syndrome along with the CAR T cells. It can be life threatening or fatal. The people who had received a belantamab, we need to interrupt or discontinue belantamab as per the recommendation. Another most severe side effect is a neurotoxicity. It also can be severe or life threatening, and you need to interrupt or discontinue the belantamab. For these two side effects, even you have the hospitalization being recommended for the first 9 days of cycle 1 and cycle 2. If you have a cytokine release syndrome CRS grade 3, you withhold the drug for a week, then restart at the reduced dose of 9 microgram per day, and if there is no reaction, then you re-escalate back to the same dose if there is no reappearance of toxicity. If you have a grade 4 CRS, then you need to discontinue belantamab permanently. Neurological, if you have a seizures, you discontinue. Grade 3, you withhold, same, you withhold for 3 days and then restart, and then if you there is no reaction, you re-escalate to the 28 micrograms per day. Similarly, if there are any other side effects, grade 3, the same guidelines, and if it is a grade 4, you need to discontinue. So far we have used in a one patient the belantamab who tolerated very well and undergone a transplantation, but we are restricted by the cost of use in many patients. The other mechanism is augmentation of immune effectors and direct targeting of tumor antigens by CAR T cells. How does the CAR T cell work? We have engineered, these are autologous T cells you collect, engineered to express the synthetic chimerism antigen receptor against tumor surface antigen. So this is antigen specific and HLA independent, similar to the belantamab. If you can see the cartoon, it has the transmembrane molecule. It has a antigen specific antibody on the top, and then you have two co-stimulatory factors. There are first generation CAR T cells, second generation CAR T cells, and third generation CAR T cells. Depends on the basis of no co-stimulatory factor, one co-stimulatory factor, or two co-stimulatory factor. What are the advantages in hematological malignancies? We have a known cell surface antigen like CD19 in the ALL and lymphoid malignancies. You have a Z sampling of the tumor, and there is a natural homing of the T cells to the hematological organs. So they directly reaches to the target. There is a easy homing into the target cells. This is a cartoon which shows you the tumor specific T cells with the binding antibodies. There is a recognition of the tumor antigen in a native state. There is a affinity of the T cells can be optimized. There is an intracellular domain which you can increase the efficacy by having a co-stimulatory molecules, and these can be engineered to express the cytokines and chemokines which can increase the further functions and migrations. There are many things you can do with the CAR T cells, and there are many things which are in development. This is a cartoon which shows you there is a tumor cell, CD19 positive tumor cell. You have a T cell, and this is a CD3 part of the CAR T cell of the CAR. There is two co-stimulatory factors, and then you have a CD19 binding domain. What are the goals of these? You need to have a proliferation, so you need to have a high level of in vivo proliferation, and more the proliferation in vivo, it correlates with the high response rate, probably more toxicity because of the proliferation. Persistence, you need to have a long-term persistent of these CAR T cells that may allow your long-term disease control, and the length of the persistent for the long-term, how long you need to have a T cells persisting, we don't know for the cure. So many things which we will be knowing in the future. How do we do it? You collect T cells by leukapheresis. You have a antibody coated beads. There is a T cell transduction or activation is through the you have a viruses, and then there is a expression. These are modified T cell expression. Then there is a beads removal. You give a chemotherapy as a lymphodepletion, which increases the expansion of the infused T cells, and then these modified T cell infusion. So lymphodepletion with the chemotherapy enhances the expansion of infused T cells, and then there is an engagement of tumor antigens by CAR T cells that leads to the cytotoxic and massive T cell proliferation, which is independent of the MSCs. What do we have learned so far? There are durable remissions have been seen in acute lymphoblastic leukemia, CLL, and non-Hodgkin's lymphoma. There is a persistence of circulating T cells have been seen more than 3 years after infusion in CLL. In ALL, there are CR rates of 90% in relapsed and refractory population, where we have a very dismal outcomes with the chemotherapy. We have a more than 90% responses, especially if you compare with the historical control. There is a significant improvement. CAR T cells have been effective even post-transplant relapses. So the people who did not respond, they have a disease which had not responded to the allogenic transplant, and people who had a chemo-refractory disease have shown durable responses. And the responses are correlated with the expansion of the, how much is the in vivo expansion, not the cell dose. What cell dose you give it doesn't matter. How much is the in vivo expansion of the cells and presence of cytokine release syndrome. More CRS, more chances of responding to the CAR T cell this thing. CAR T cells, the CNS disease also have been shown to be cleared with the CAR T cells. The disadvantage has been a B cell aplasia. It leads to the depletion of the normal B cells, but the B cell aplasia is a surrogate marker of persistence of CAR T cells. So if you have a more prolonged B cell aplasia, that means the CAR T cells are persisting. You can have antigen positive relapses or antigen negative relapses. So antigen positive relapses occurs if the CAR T cells disappear. So if there are no circulating CAR T cell, you can have antigen positive relapses. You can have antigen negative relapses even in the presence of CAR T cells. The CAR T cells are there, the cancer cell is smart, does not express antigen and can have antigen negative relapses. So it is not, and one other point, you need a one co-stimulatory factor, which co-stimulatory factor, whether you need both the co-stimulatory factor. So that we have a many generation CAR T cells, we need to figure out which one is optimal in the terms of efficacy and in the terms of minimum of toxicity. CD19 CAR T cells got FDA breakthrough designation in July 14 in relapsed and refractory ALL. Antigen discovery is going on. It's not only restricted to the lymphoid malignancy. You can have a more cancer antigen which is the tumor is specific, have a minimal side effects and more efficacy. Similarly, we have anti-BCMA in multiple myeloma, which has shown a significant responses in the recent trials. There are 41 trials actively enrolling CAR T cells in the various hematological malignancy. There is an exciting era where we will have a less of chemotherapies, more of our monoclonal antibodies, more of our drug conjugates, more of our bispecific antibodies, and more of a CAR T cells, and the combination of all these things. So we'll have a more of a combination of immunotherapy and less of a chemotherapy. So we are going towards an exciting era, but the side effects also are different. The side effects of chemotherapy we are very familiar. There are similar kind of side effects. The different kind of mechanisms of the monoclonal of immunotherapies, they have a different side effect profile, and we need to get experience with these the immunotherapies. Toxicities related to the CAR T cells, because you're using a viral vector There is a insertion oncogenesis, not so much so far. Cytokine release syndrome, I'll come to that. Significant toxicity with the CRS. There are more than 10 patients have expired because of the CRS. You can have anaphylaxis or allergy, the immune responses to the mouse derived or recombinant proteins. You can have on target or off target toxicities. Is a B cell aplasia is one of the toxicities, and we don't know the mechanism of how the neurotoxicity develops. You can have a neurological toxicities from mild to severe form. So these are a different side effect profile which we haven't come across during the chemotherapies. Inflammatory response processes related to the expansion of T cells associated with the cytokine elevation. More T cell expansion, more cytokine release. All patients who respond to CAR T cells have developed some form of CRS. Fortunately, mostly is mild and manageable, but occurrence of CRS correlates with the response. If you don't have a CRS, you don't have a response, but fortunately the severity does not. So it doesn't mean if you have a mild CRS you will not respond. If you have a severe CRS you will be more likely to respond. So fortunately the severity does not correlate with the response. Mild is in the form of high grade fever, myalgia and flu like symptoms. Severe is mostly a capillary leak, vascular leak, hypotension and multi-organ failure. Only predictor who will have a severe CRS is a high disease burden at the time of treatment. So more the disease burden, you have a higher chances of severity of CRS. There are many guidelines exist. Steroid, anti-IL-6 antibody is tocilizumab, more commonly used in rheumatological diseases. But fortunately the use of tocilizumab does not impact your anti-tumor response. It will reduce your CRS but will not reduce your efficacy of your cytokine. These are the various graphs showing you the predictors of CRS response. I'll not go through this. These are the clinical signs and symptoms of CRS. Constitutional symptoms, as I said, the fever, malaise, anorexia, arthralgia, headache. Then the system wise, the rashes in skin, nausea, vomiting, diarrhea, tachypnea, hypoxemia, tachycardia, hypotension. You can have a DIC kind of a picture, renal failure, transaminitis, hyperbilirubinemia, neurological mental state changes, confusion, delirium, aphasia, tremors and seizures. And you can have a HLH as a presentation of CRS. How do we manage? Does the patient has a morphological residual disease? You monitor and discharge home. There are no CRS. If you have a CRS, if the patient has fever, then you can have a levetiracetam. And if there are any other clinical signs or as present, and if there is a CRP is more than this, you can consider for ICU transfer. So there are various guidelines have been given for CRS strategy. If you have a lower grade, you be vigilant and give a supportive care. If it is a higher grade, then vigilant supportive care, and then consider for tocilizumab and corticosteroids. Monitoring, you need a ICU monitoring if it is a higher grade. Other toxicities is a neurological and mainly encephalopathies. All the groups have reported a neurotoxicity after the CAR T cells. Significant CSF infiltration have been reported, so probably it is related to the infiltration by the CAR T cell. It ranges from confusion to seizures. It may require a mechanical ventilation. We don't know the mechanisms or neurological toxicities. Unfortunately, the IL-6 antibodies does not prevent the neurological toxicities, and it is an unexpected on-target toxicity. The B cell aplasia is expected on-target toxicity. It provides a pharmacodynamic marker of CAR T cell persistence, and the people who have developed a severe symptomatic B cell aplasia require IVIG replacement to prevent the infections. Acute neurotoxicity, there is a global encephalopathy which we have discussed. Usually it is self-limiting and without a long-term sequelae. So usually there are not long-term side effects. It is not related to CRS. It has no correlation with the CRS, and it is not prevented by tocilizumab. As we discussed, this is a B-cell depletion. Off target, there are various antibodies, and there are off target toxicities have been mentioned. How do we manage? Mainly the steroid and tocilizumab, and being a strong vigilance is a treatment. What are the current challenges with the CAR T cells? There are various challenges with the CAR T cells itself. The structure of the CAR T cell, as I said, whether it's you need a one co-stimulatory, you need a second co-stimulatory factor to be added. What should be the structure? There are various things have been discussed. Which vector we need to use it as a lentiviral or retroviral vector, composition, what should be the CD3 and CD4 ratio, what should be the ideal dose, how would you condition a host, ideal tumor lymphodepleting chemotherapy, and then the toxicity management. So these are the various challenges which will require more experience and more data. I think the major challenge with us is cost and the logistics. Optimizing the similar way, it is how do you engineer, what should be the ratio, the different targets, what should be the ideal duration of engraftment, what is the impact of tumor micro environment, whether you can combine it. There is some evidence you can have a PD1 or the PDL1 more expression in microenvironment if you use a CAR T cell. So whether if you combine them with the checkpoint inhibitors will have a more efficacy. Strategies to approach antigen negative relapses, and then major obstacle I think is a financial obstacle. So we have a financial toxicity. I think this is going to be a technical, regulatory, and then there are financial obstacles. Another mechanisms is NK cell alert reactivity. There are phase 1 studies of adoptive immunotherapy using NK cell lines, still in a very primitive phases, but there can be exciting eras. Vaccines, we have not been very successful with the vaccine. Many of them have been tried in AML. We don't have a much of a success with the vaccine, but sooner we'll have some success. Overcoming the tumor derived immune inhibition is an immune checkpoint blockage. This is a cartoon showing it. The tumor evades T cell immunosurveillance by expression of PD1 and PDL1, and whether we can prevent this tumor derived inhibition. There are many things have been in the development. Mostly they have been used in a solid tumor. We've not been very lucky with the checkpoint inhibitors. Hodgkin's lymphoma has been a leader in hematological malignancies in the use of immune checkpoint inhibitors. Why these checkpoint inhibitors are effective in Hodgkin's lymphoma, not in other malignancies? It has a uniquely vulnerable. The RS cells are typically surrounded by the immune infiltrate. So there is a less of the malignant cells have a large immune infiltrates that makes an ideal target for the checkpoint inhibitors. Hodgkin's lymphoma has a genetic alteration 9p24 deletion, which results in the copy gain for PDL1 and PDL2 and overexpression. And EBV infection also leads to the PDL1 overexpression, and there is increased expression of PDL1 in the tumors have been observed. So there are various mechanisms have been explained in Hodgkin's lymphoma that leads to the PDL1 expression in Hodgkin's lymphoma, and that makes them ideal this thing. There are two drugs, nivolumab, phase 1 trial using combinedly into the relapsed or refractory myeloma, non-Hodgkin's lymphoma, Hodgkin's lymphoma, and there is expansion cohort in Hodgkin's lymphoma. There was a 23 patients with the median 5 lines prior therapy, and they showed a very good response of 87% with a CR of 17%, and the expression of PD1, PDL1 and L2 have have been observed, and that is correlated with the response, and that got a breakthrough designation in 2014. Similarly, the pembrolizumab phase 1 studies, 15 patients, almost a similar kind of a response, and the responses with both the drugs appears to be durable, but the long-term follow-up is needed. There are a use of immune checkpoint inhibitors pre and post transplant. Post transplant, you can have a minimal residual disease, whether you can use these PD-L1 inhibitors. Immune reconstitution leads to the increased there are more lymphocyte subsets which can be a target of PD-L1 inhibitors. So if you can use more of these drugs post transplant, whether they can have still a graft versus tumor, they can enhance your graft versus tumor effect. How much is the impact on the graft versus host disease, which we need to analyze. So using these checkpoint inhibitors pre and post transplant, whether they can enhance the impact of transplant, which we need to use it. One of the checkpoint inhibitor being a pembrolizumab, it has been used in a phase 2 study in 72 patients with the diffuse large B-cell lymphoma post autologous transplant. The 18 months progression free survival was 72%. Important thing is the out of these where this drug was used, they had a relapsed refractory patients, which had a 51 patients that had a measurable disease after the transplant. So the disease had not gone down even with the transplant, showed a significant progression free survival with the use of this anti-PD-1. So whether you can use it a post-transplant setting to for minimal residual disease. Aplumab has not been well studied in hematological malignancies, but this also can have some preliminary data is there whether you can utilize it in a post-transplant setting. This was a phase 1 study in relapses post allogenic transplant. There was no severe graft versus host disease or there is no severe graft versus host disease or the toxicities have been seen. Some evidence of anti-tumor activities. There was a 2 CRs for the post-transplant relapses and 1 PR. This is the kinetics of the toxicities. These checkpoint inhibitors have a different toxicity profile. The people who treat the solid tumor will have a more experience with the toxicities associated with the checkpoint inhibitors. We hematologists will have a lesser experience, but slowly with the use in the Hodgkin's lymphoma and the transplant settings, we will be gaining experience. So I will be reading more of a theory rather than giving my own experience. Various toxicities with the grading. They come with the typical timeline and the severity. So you can have a skin rashes and pruritus, liver toxicity, diarrhea, colitis, hypophysitis at different time points post use of the drug, and they subside at the different time pace. This shows the time to resolution of the 2 to 4 immune mediated adverse events. There are various diagrams showing the skin rashes. There are various biopsies from the colonic. This is the colonoscopy and the biopsies showing immune mediated side effects, and there are dermatological side effects, and this is a pneumonitis which you can see on the CT scans. The 3 to 5% of the patients who are treated with these drugs have shown these, rarely with anti-CTLA. This can be severe and life-threatening. Median time to onset is 11 weeks. So these are the side effect does not appear with the infusion. You would have given a drug now, and the toxicity will be happening few weeks down the track, and median time to resolution is around 4 weeks. So we had to be longer vigilant with the newer drugs. This is a summary of the safety profile. If you're using nivolumab and ipilimumab, there are higher. If you're using a combination of PDL inhibitors, there's a higher grade 3/4 toxicities. If you're using as a single agent, there are lesser grade 4 toxicities. These are general management guidelines have been published throughout all the journals. Neurotoxicity is one of the side effects. and then there are endocrine side effects, there are gastrointestinal side effects, there are pulmonary side effects, there are ESMO guidelines about the grading and then on the examination and assessment, and what actions you need to take it, whether you have to discontinue or what actions you need to take it in the terms of treatment of toxicities, hepatitis, then GI symptoms. I'm not going through the each and individual, so the depends on the grade, depends on the organ involvement. You have a various options to treat the checkpoint inhibitors side effects. Immunotherapeutic agents have a different mechanism of actions from the cytotoxic agents. There are different event profile. To prevent these effects, you need to select the patients before giving the drugs, identify the disseminity risk factors, so the various risk factors. You need to have a baseline assessment done, monitor the patients for the sign and symptoms, lab changes which may indicate the onset and offsite treatment, rule out the other etiologies. Any sign and symptoms coming it, you need to rule out toxicity, the immune mediated toxicity before, unless you have other etiologies. Initiate a prompt and appropriate treatment, and eventually interrupt immunotherapy based on the grade. Many of the side effects are mild and moderate. You can have a severe and life-threatening do occur, but you need to identify and then appropriate management, mostly in ICUs. Many of these can be reversed and may allow the patient to resume immunotherapy after the resolution. So there are various guidelines, especially the ESMO guidelines are there for the grading, assessment and the treatment, and whether you need to go back or not. You need to educate the caregivers and patients on the signs and symptoms to stress whether they immediately have to seek the attention. What is the future direction for the immunotherapies in hematological malignancies? There are ongoing development and refinement of the antigen discovery, more antigens, more applications, novel immunotherapies, various mechanisms, broadening the availability. So you need to have availability in beyond the highly specialized. So you cannot restrict these to the higher centers. More and more patients can have accessibility to these high-end, highly technical the treatments. Developing the experience, we need to develop the experience for the handling of complications, which we are not as a hematology. More of the checkpoint inhibitor experiences are with the solid tumors. Then developing experience in developing appropriate clinical endpoints and response assessment. The exciting era will be a combining immunotherapy, so A to B, A plus B plus C, and then we're seeing how much is the efficacy. So we are seeing a more longer duration remissions, different toxicity profile. We need to get a more experience with this. Future, can it be used as a bridge to the transplant? Can it treat the post-transplant relapse? Someone has been unfortunate, the transplant has not worked, whether we can use these various immunotherapies for the post-transplant relapse. Treatment of transplant ineligible patients or someone who doesn't have a donor, if the transplant is not an option, whether these immunotherapies can be a curative ornaments as a complement to the transplant for enhancement of graft versus leukemia effect. Whether we can use them, whether we can at some stage, whether we can replace a toxic allogenic transplant with the immunotherapy. So chemotherapeutic blunt weapon is the allogenic transplant is called as a bluntest immunotherapeutic weapon, whether we can have a magic bullet. With this I'll stop here. I'll encourage to have a discussion. We can go through the various toxicity profile, and I'm happy to answer the question. Management, the question has been asked, management of botulinum induced peripheral neuropathy. Botulinum is not immunotherapy, is a targeted therapy, but it's not immunotherapy, is a proteasome inhibitor. Using a right dose, using it subcutaneously, using it once a week, recognizing early the neuropathy is the best preventive strategy. Once you develop a severe neuropathy, then it's more difficult to treat it. So I would suggest using a various strategies, using a right dose, using it subcutaneously rather than IV, and using it once a week. You can start with the IV, or if you have aggressive disease, you can start with the IV or every 4th day. Then once you have achieved a response with the 1 or 2 cycles, switch back to the subcutaneous or once a week. The treatment of peripheral neuropathy will be the same, using pregabalin, using duloxetine, then sending them to the neurologist for the various treatment. So the treatment of severe neuropathy is more difficult. We can do many things to prevent development of severe neuropathy. There are guidelines for reducing the dose of botensilimab as per the grade of neuropathy. Good afternoon, sir. The another question is, good afternoon, sir. Can you throw some light on the immunogenicity of rituximab in your clinical practice? I don't know what you mean by immunogenicity. It's been a relatively well tolerated drug. It has been used for many years as a maintenance, have been used multiple times with the multiple relapses in lymphomas. Not much of a side effects. When I say not much of a side effect, there are some side effects. You have infusional toxicities, mostly with the first dose or the second dose. We have to give a pre-medication to reduce the toxicity. We have to stop the infusion if you have an infusion toxicity. Few patients can have a toxicity with the subsequent infusions also. We may have to not to give a rituximab if there are severe toxicities reoccurring, the infusional toxicity is happening. We will be aware of the hepatitis B activation, so we should always check for the hepatitis B, HBsAg and the core antigen, and if there is active the hepatitis B reactivation, you need to treat it. So you need to be aware of starting the dose of rituximab in the hepatitis B setting and monitoring for the hepatitis B. Some people can have a leukoencephalopathy. Is a very rare side effect, but is a serious side effect. Some people can have infectious complications. These are the major side effects which I am aware of. Usually very well tolerated. I have only these 2 questions. If someone wants to ask a question, I am happy to wait. We have a 15 minutes time, which we can go through the various aspects of immunotherapy. Are there any questions? Will they not come here? What is the most important concern with the PD-1 inhibitors? Mostly we need to have a right indication. There are not many diseases we can use the PD-1 inhibitors. There are many there are infusional toxicities, then there are many immune related adverse events are there. As I said, the serious ones is the neurotoxicity and mainly the neurotoxicity. So we have to be aware of most of the side effects have been lower grade and easily reversible, but you can have a high grade toxicity, higher grade toxicity, and which will require, sometimes it can be life threatening. So we need to be aware of all these side effects. Thank you.